right. Good morning, everybody, or good afternoon, wherever you are. Happy to see you all, and thank you for sharing with me a little bit of information about the weather you have where you are. I am Amy Cohen from SMI Advisor, and I am going to be your host today. So I'm really looking forward to that. Today, our featured speaker is going to be Bruno, who is going to talk to us about the fact that it's time for a dedicated behavioral health crisis response. Now, Ron's presented before, but we felt like it was really important to have him back now as we continue to think about the involvement of the justice system when people are in crisis. So we're going to talk about that a little bit later today. So big news, we've crossed over 2,000 on our newsletter list, which is just huge, and I'm really excited about that. And we're looking for more Medicaid partners. So if you know someone who wants to join the Crisis Jam and is a Medicaid partner, we'd love to have them. Of course, we'd love to have anybody, but in particular, we're looking for that crowd if you have one. We want to talk a little bit on the next slide about remember that you can always visit. If you happen to miss a call, go to Crisis Talk. I actually recommend going to it anytime, even if you're on this. You'll notice that there's a lot of really good information here. And I know that this call can sometimes feel like you're sort of drinking from a fire hose. So if you've missed something or you're like, what was that again? Remember, you can always go here and hear the recordings, and we would love for you to visit that. There's also quite a few tools and things here that are helpful. And I want to turn it over just for a minute to Karen to talk a little bit. If you're a person that doesn't have a calendar invite for this call, Karen, what can they do?
So we do have a way to download an Outlook calendar event series. So those that have gone before onto the Talk Crisis Now right here where it says sign up for weekly reminders in the newsletter, there is a link directly to join, but there is also a download link at the very bottom of that email to open up the event series. And also we've just dropped that link into the chat so you can download it that way as well. If you do not have an Outlook calendar, if you use Google or some other system, then the other option would be to just start an event series on your own manually and copy the link directly that way. Of course, you can go to the talkcrisisnow.com to access the link or sign up so that you get the weekly reminders. But the event series is going to be the most reliable. And we've had a few people who had it before that are having some issues with it with the event series when we change platforms. So this would be a really good tool for you. And if you have any problems, just email me directly or reach out through our site, and I will help whenever I can.
Thanks so much, Karen. It is important for us to have all these different voices every week. So I'm really, if you don't have us on your calendar, get us on your calendar and definitely visit this website. There's lots of little information to catch you up on anything that you might have missed on a call. All right, next slide. So we have our quote of the week this week, and as we get ready to hear from Ron, this is a quote from him from a few years ago. We have to challenge the belief that mental health crisis services must come in a police car. And this is something that I know that this group has been talking about for a long time. And that's why we're really looking forward to Ron talking to us today about how we need to think about this and how can we move beyond that kind of thinking, not within this group, but within our communities and within legislators and all the other people who still believe that that is a critical part of a crisis response. So I wanted to, we've been enjoying Stephanie's interviews each week, and I wanted to ask you, Stephanie, today, if you could talk a little bit about your recent interview with Dr. Joe Parks.
Yeah, so that's right. So we spoke I think it was actually a few months ago, and he talked about, just so you know, he's the medical director for the National Council. And he shared how common language really can maximize 988. Dr. Parks, are you on the call by any chance?
Yes, I am on the call right now. Pleasure to join you. Thank you for having me.
So if you could talk a little bit about what can go wrong, especially you focused on providers and insurers who don't speak the same language. And you gave a really great example of how two people who can look very similar, how the decision-making can really alter outcomes for people, and why that common language really, really matters.
You know, the common language is really about taking into account, to a large part, social determinants of health.
Mm-hmm.
The current prior authorization criteria in use with many of the major insurers looks almost solely at the severity of the symptoms and the level of risk. And what it doesn't look at is things like how stressful is the environment the person is in, how supportive is the environment, what's the person's prior history of resilience, have they not been ill before, been in a crisis before, does this happen to them all the time and it's the third time this month. It doesn't look systematically at all the possible comorbidities and weigh them together. It looks at the one chief diagnosis they're considering right then and doesn't consider those interactions in the level of service a person needs altogether. So there's been movement recently towards requiring multidimensional assessments that, beyond looking at symptoms and risk, look at these other factors. And it really came to a head with a lawsuit in California called the Witt decision, where the court held that it really is the community standard of care to consider these other factors, and these are criteria that have been agreed upon by professional associations like the APA. Their standards were also acknowledged as the community standard of care. And when I really insisted in Missouri some years ago that our managed care companies use this instrument, the companies were initially concerned it would disrupt their operations, but in checking with them 6 to 9 months later, they said, well, no, actually, this is a better framework. We can have a conversation with the provider about what's important. And how this came to my attention really is we got some cases where the hospitals were saying people were discharged too soon. Mm-hmm. And we looked at a couple of the cases and we came to understand you could have two 12-year-old girls who had recently attempted suicide. And you could have one 12-year-old girl where it was the first time it ever happened. She was living with her mother in stable housing and mom didn't have any particular problems. And you could have another 12-year-old girl where this is the third admission in 12 months. And mom was in unstable housing, living with friends one time, with family another time, and herself had a mental illness and a substance use disorder. And you would get the same length of stay on the current prior authorization algorithms the companies was using, where clearly these are children that have very different needs for level of intensity. And perhaps the other child doesn't need to go right home, but needs step down to residential or something, but that isn't taken into account unless you look at that prior history and social determinants. And this is a really great tool for a crisis system because you get somebody you don't know that much about, but clearly you're aware of those social factors. And I know some crisis systems are now using this kind of level of care approach. And I think we're going to have somebody talk with us about that because it's a great tool.
I think California, I believe they're doing something similar where they've integrated the entire family, the Lucas family of tools.
And I think, this is something that's been, I'm glad you're highlighting it. I know that the American Psychiatric Association in their recent mental health services conference made social determinants of health the theme of the whole meeting. And we'll also be doing that for their annual meeting in 2022. So I think a lot of people are wondering, they know that this is important. They're wondering how to integrate it into their assessment and their responses. And so I think this is something that's right on the nose right now. People are really starting to think about it, along with everything that's going on in the community around social determinants, differences in backgrounds, et cetera. So great interview. I know that several people in the chat wrote that they really enjoyed reading this. So thank you both, Dr. Parks and Stephanie, for presenting a little tidbit today on this interview. I want to turn to our featured speaker today, Ron Bruno, who's going to talk to us about the dedicated mental health crisis response model. Ron, are you on? Oh, there you are.
I am.
Oh, wonderful to see you. Well, welcome, and we're looking forward to hearing from you today, a little update on thinking around crisis response.
Excellent, excellent. Well, thank you, Amy. So what we want to talk about today is the different types of crisis response models. Too often, we actually focus in on a component of a crisis response model, and we call that our crisis response system. We really need to look at it more holistically, every single feature and how they tie in together, and that's exactly what we want to do today. Next slide, please. So if you actually think about it, crisis response system models really fit into these three categories. The law enforcement model, which is the most popular and historically the one that is most often used, not only here in the United States, but throughout the world. And that's where we have law enforcement as the primary responders to crisis situations. It starts through 911, and basically we then send law enforcement officers out to deal with the situation. Now, there has been some adaptations to these different types of models. So, for example, in the law enforcement model, there's the adaptation of having officers with iPads. So we send out officers who respond to a crisis situation and have an iPad that basically connects that individual through that technology with a counselor, crisis worker, or clinician. The next is the embedded co-response model. And I really want to emphasize the embedded co-responder model. I mean, I think that co-response is a fantastic idea, and I don't think anybody would actually argue with that if it's used selectively. Embedded means that we're always going to be sending law enforcement out. And I think that the whole idea behind the model that CIT is dedicated to is realistically to reduce the times that law enforcement are involved in a crisis situation and only utilize law enforcement more strategically at those times when a level of danger or a criminal concern warrants the actual presence of an armed law enforcement officer. And then the third model is the dedicated mental health crisis response model. So the CIT model, I call it. And the reason for that is because realistically, this is what CIT has been advocating for many, many years, is to really step away from just having all the responsibility on law enforcement and build up the mental health system. We've got to remember CIT was built on the idea of diversion. And fortunately, now we know we can divert earlier. So let's walk through the dedicated mental health crisis response model, the CIT model. Next slide, please. So on this screen, I'm just going to walk you through a call for service. You'll notice that there is that blue line down the center. The reason why that blue dotted line's there is because we want to actually keep two separate systems separate. But what we want to build is connections. Connections at the time that we can divert somebody from one system to another, or that we need to rely on the other system to support some type of crisis situation. On one side, we have the gentleman in the blue. That's representing the emergency call center or the 911 center. On the other side, we have the individual in the gray shirt. That's representing the crisis line services. So basically, we have the criminal justice system because, yes, 911 is the gateway to the criminal justice system on one side. And on the other side, we have the mental health care system. What we want to do is not necessarily integrate and combine these two systems. We want to keep them separate again. But what we want to do is have a connection. Next slide. So we want to be able to have a call come into a 911 center. We want to train that 911 call taker how to triage the call. You know, we already do this all over the country. We prioritize calls. Every single 911 center prioritizes calls. And we need to continue that with mental health calls for service. It is being done successfully in Broome County, in Houston, Salt Lake. They are actually successfully being able to triage those calls. And then if they make a determination that law enforcement isn't required, they can do a warm handoff to a crisis line. With 988 coming out, that is a number that is an option for areas that do not have a very local crisis line service, to be able to kick that over to 988 and get it into a call center, a crisis call center, to see if it can be resolved. You know, we do know and I've proven this time and time again by going around speaking to law enforcement officers and trainings and say, hey, raise your hand if you'd say that the majority of crisis calls you go on require a law enforcement. And I haven't had a hand raised yet. Because it is true that the number of calls that are going into crisis or into 911 centers do not require a law enforcement response. So those could be handed off to the crisis line. We also know that some of the statistics that are starting to come out, that the majority of calls that go into a crisis line are resolved at that level and do not require any type of response. There's also another benefit, next slide, that we can have with this kind of system. And that's a warm line handoff, generally tied in with the crisis line. Warm lines are generally serviced by certified peer specialists, individuals with lived experience that can understand what a caller might be going through. And this is a great benefit because too many, or often, an individual that does call into a crisis line, it's not necessarily an emergent situation, but it is a situation where they need an empathetic ear for an extended period of time, and that's where a warm line can actually fit in. For those of you that know me, you know that I have a law enforcement background, and you know that I've actually helped develop this system in Salt Lake County at 1 year. Unfortunately, it wasn't fully funded the way that it should be, and that's one of the issues that we do need to talk about is how do we fully fund these types of systems. But I can tell you my experience with the warm line. Any law enforcement officer or even a call center call taker can actually express how they have individuals that they can identify who are individuals who continue to call in, whatever they're called, familiar faces, continual callers, constant callers, whatever the term that is appropriate for that jurisdiction. It's somebody that continues to call 911, but does not really require 911 services. And so too often we get tied up sending somebody out to deal with them, doing a welfare check, and then turning around and basically doing nothing just to have that situation happen time and time again. I have seen where the warm line services have built up rapport with these individuals and are able to say, hey, next time you're experiencing this, instead of calling 911, just call into our crisis line and ask to speak to one of us, and we'll be glad to talk with you. And that means that we are reducing the calls that are going into a 911 center. We are also not tying up our crisis line because we have the service. Next slide. Now, we're not going to be able to resolve everything at that level. I mean, ultimately, we are going to have to send resources out to situations. Well, over on the 911 side, we do already have the resources of EMS, emergency medical services, and law enforcement services that we can send out to handle any type of a situation. Next slide. But what we really need to do is look at developing that non-law enforcement crisis response service. My colleague, Dr. Amy Watson, a couple of weeks ago actually spoke about that we need to build up this workforce. And absolutely, we do need to build up this workforce. But just as we know that the majority of calls that go into 911 do not require a law enforcement response, we also know that the majority of calls that law enforcement would go out on that we do need to send somebody out into the community does not require law enforcement. We can send out this non-law enforcement crisis response team. And this is growing in popularity. I mean, we have had a huge history with this type of team with the CAHOOTS. That's what this component is based out of, is the CAHOOTS model, where they tied in a crisis worker with a medical personnel. And that is one type of non-law enforcement crisis response team. Other teams are made up of clinicians and certified peer specialists, again, bringing that certified peer specialist, that lived experience right out into the field when it's appropriate. Other teams, such as STAR in Denver, the San Francisco model, they're kind of even taking it a step further, where they're tying in clinical services as well as medical services, as well as certified peer specialists. Now, next slide, please. Just as we had that connection up above between the 911 call taker and the crisis line, we want to also build that same type of connection at this level. There will be times that we do need to send law enforcement officers out, and that's why every single jurisdiction deserves to have a cadre of specially trained patrol officers. Again, specially trained patrol officers, and this is the CIT model, where we have a group of patrol officers who have volunteered to become CIT officers, who are then, they go through some type of clearing to make sure that they have the suitable skills needed to be a CIT officer, and they get that training. And then when a situation comes up into the community that requires law enforcement response, they in patrol are the ones that are going to be assigned that call and go out and handle it. And the reason why we want to keep that into a patrol basis so that we have that immediate response ability or capability by sending a patrol officer, but especially trained one called CIT, of course, to go out and handle that situation. That CIT officer is trained on how to recognize that they're dealing with a mental health care situation. They're also trained on how to de-escalate it, which realistically every single officer needs to be trained on. But more importantly, they're trained on the resources in their community, and above and beyond, they have a deeper understanding of mental health services. They understand medications to a point that they can talk to an individual or a family member about medication use and why somebody may not be compliant. And more importantly, they are trained on how to work with that non-law enforcement crisis response service. So in other words, the 911 center can send out that CIT officer. The crisis services can send out that non-law enforcement crisis response team. They respond out together, meet on scene. They're not embedded, but they meet on scene, and they can work as a co-response team. Just as the embedded co-response team works together, these two teams can work together on scene and resolve that situation. Now, we're not going to resolve everything at this level either. Sooner or later, we're going to have to take somebody out of the community to get them further assistance. Next slide, please. So if you look at this model, it's the common thing that we've all been talking about: the right person to talk to, the right person to respond, and the right place to go. So we need to have services that we can actually deliver individuals to get that further help. Of course, we already have the emergency rooms, which are the most popular to be used for crisis situations if somebody is going to be taken out of the community. But of course, we also want to be building crisis response centers. Those are generally freestanding centers outside of a hospital setting. They are built on the living room model. Everybody kind of knows about what that is nowadays. But the whole idea is that, you know, it's not dealing with a crisis situation in the hustle bustle of an emergency room. The bright lights, the running up and down, the loud noises, the talking, the laughing, the yelling that goes on into an emergency room. And if you actually look at an emergency room, I mean, their whole concept behind an emergency room is basically to get them in, stabilize, triage, and either discharge or hand off to a specialist. Well, that's not the way that we really can handle a crisis in the best manner. The crisis response center, of course, can deal with that at a lower pace or a slower pace. Now, yes, I understand that having a crisis response center is an expensive opposition or an expensive situation to try to build in every community, and not every community is going to be able to have that access. So there is another thing called an access center, of course, which many of you know about, that is tied into an ER. Or I should say tied into a hospital. And the way that it works is it's built just on the same principles as the crisis response system center. However, it is part of a hospital system, but it's separate from the ER. If done appropriately, individuals can be admitted to the access center without having to go through ERs. And that works nearly as well as the crisis response centers. The only problem that I have seen, that I have experienced, is that too often we have hospital administration that says, oh, there's a liability issue, so we want to have that pre-clearance for ER, which again takes somebody in crisis and puts them in that environment that maybe isn't the best environment for them to be treated in. Next slide. But you know, as we're starting to look at building crisis and reforming crisis response systems, what we really want to do is just make sure that we are developing systems and reforming systems that are the most compassionate, the most effective, and the least intrusive that they possibly can be. Next slide. So I just want to thank you for the opportunity to speak with you today. If anybody does have an interest to learn a little bit more about CIT and CIT programming, please visit our site. You can read this book online, free downloads, and you can learn a little bit more about the thoughts of what CIT is. So with that, I'll turn it back to Amy.
Ron, thank you so much. I really appreciated this very clear walkthrough of where we need to be going. And I want to turn to our roundtable participants. Sabrina Taylor and Dr. Watson. Would one of you like to start and give us a few reflections?
This is Sabrina Taylor. I guess I'll start. I'm looking for Amy, but my screen is so small.
Yeah, she's here, so you go ahead and start.
All right, great. Well, like Ron in a previous life, I am also a law enforcement officer, and I've been lately digging through a lot of publications and research that very recently came out, looking into the possibility of diverting calls from 911 to other possible responders. And it's interesting because CIT has been doing it for so long. And recently there was a study done of 9 different agencies, but one of them being Tucson, Arizona. And the things that they found were that we're already diverting behavioral health calls, at least here in Arizona, in a large majority to our behavioral health partners. So I think it's great that there's focus on this. I think it's great that we're able to do these things. It's wonderful that we have behavioral health partners that make it so easy for us. And it would be great to see this spread further around the country, because I know some parts of this country don't have the robust crisis system that we enjoy here in Arizona.
Thank you, Amy.
Sure. One of the things that I really like about the model, and as Ron laid it out, is that over time, I really think too, it helps people sort of shift who they call when they're in a crisis. So if people are so used to calling 911, and we certainly have trained people to do that, that as they, have different types of crisis responses, get connected to warm lines, or can call the crisis line directly, and also have access to services on that side, we could actually see people shift kind of how they reach out when they're reaching out in a crisis. And I also think it will allow people to reach out sooner, because dialing 911 is sort of a big thing. Particularly when there's a concern, that it's going to bring police. So if we start helping people kind of be aware and learn how to access these other types of services, we will see that shift. And of course, the key will be making sure those other types of services are available and responsive, and really working to make sure that we support that capacity growth on the mental health and behavioral health side is going to be really important.
I agree. And I hope this wave continues across the country as we're in this moment where we're really making a change and focusing on crisis response. Ron, did you have any last keywords that we should have as a takeaway?
The only thing I would add to that is I was reading a little bit in the chat as it was coming around, and yeah, this is a great topic for us to discuss. And yeah, there's going to be a lot of different opinions and thoughts. I mean, there are some individuals that are going to think that, crisis situation is a dangerous situation, and we should have that security measure when we're going out. But I think that if we do look at programs and communities that have implemented non-law enforcement crisis response services, that they can be trained to be able to deliver that service in a safe measure. In fact, CIT International in 2022 will be developing a program of Train the Trainer to actually train crisis responders how to interact safely. And it's being developed on the existing training that we have utilized for law enforcement officers for years and years. So we can train the crisis response teams, non-law enforcement, how to respond safely as well.
Mm-hmm. Thank you so much. I think you're right that a lot of people pause because they are concerned about the safety of the team going out. And so there's a pause there. And we also have to remember, though, the trauma that can happen to the individual who's in that moment if it's not handled well, extra trauma on top of the crisis. So I really appreciate you leading us through thinking about this. And I know that people have some feelings about this, so I'm sure we'll be circling back to you again. And I appreciate you coming on for a second time today.
Absolutely. Thank you again.
And thank you both, Detective Taylor and Dr. Watson, for your comments. We appreciate it. And if there are any comments in the chat that you want to reply to, feel free to keep the conversation going as we move forward on the Crisis Jam. So now I am happy to say that we're going to hear from Samsa. John Palmieri, would you like to give us a little update of what's going on your end?
Sure. Thanks, Amy. And good to see you and good to see everybody. So a couple of things that I wanted to provide some updates on from the federal perspective. The first is just a quick update that's not really crisis specific, but people probably have seen that CMS has put out its final rule on the 2022 physician fee schedule, which continues to extend access around home-based services and audio-only services for mental health and substance use disorders, and particularly also allows audio-only services for mental health conditions in rural health clinics and FQHCs, which again, I think is pretty exciting in the interest of decreasing barriers to care and promoting access to care. And then I also wanted to provide an update that's more 988 specific. And as we have shared previously on this call and in other conversations with partners, our 988 and behavioral health crisis team has been very focused in the near term on strengthening and enhancing the Lifeline network. And we've talked about this before, but just to kind of quickly recap, our team is organized around 4 primary pillars of activity. These include federal planning, which includes providing robust federal funding, leadership, and policy direction in place to strengthen the Lifeline network and the broader crisis continuum. Pillar 2 is really focused on operational readiness and making sure that the Lifeline network is equipped to respond to the projected contacts with full 988 implementation in July of 2022. Pillar 3 is focused on public awareness, which includes educating key partners about 988 planning activities and the broader public about how and when to use 988. And Pillar 4 is addressing issues across the crisis continuum, which includes putting in building blocks and a foundation really to ensure that there's a robust and responsive crisis system that provides direct life-saving services to all in need. And specifically, I want to share an update with you that focuses primarily on Pillar 1 and specifically on federal funding. The Samsa team, 988 Behavioral Health Crisis Team, along with our partners in HHS and the Secretary of HHS, have been working intensely to increase federal funding available to boost the Lifeline network. And in that spirit, this week we announced a funding opportunity of $152 million in a cooperative agreement with Vibrant, which most of you know is currently the administrator of the National Suicide Prevention Lifeline. Those funds will be used to fund improvements and expansion of the Lifeline backup centers, text and chat centers, and Spanish language crisis centers. This is on top of the $24.6 million that Vibrant has already received as part of the FY22 budget. In addition, there's another $100+ million more to be announced later this month that will be targeted for states and territories to support them building up workforce across local call centers. And again, that funding that's directed towards states and territories is really in the spirit of a federal state partnership, which Samsa really sees as essential in advancing the crisis system. So the bottom line, with the funding, Samsa will work to use the $177 million to shore up and scale up, strengthen and expand core Lifeline network operations and telephone infrastructure needs, that funding coming through the president's budget, and then strengthening and expanding centralized chat and text response services, backup center capacity, and Spanish subnetwork services. And those funds coming from both the president's budget and some additional funding that we were able to secure through the American Rescue Plan. And then the 100 plus 105 million, I think to be exact, will be supporting staffing up at the state and territory level to build up workforce across local crisis call centers. And again, those are through ARP funds. We'll be sharing more details on the state component of our funding in a few weeks, but wanted everybody in the group to be aware that we are really working hard to mobilize rapidly to try to boost federal support for 988 implementation efforts. And I understand there probably will be questions about all of that, and people can feel free to email me directly. I'll throw my email again in the chat for people if they have follow-up questions. And I think there are other people on the team here, including Richard and James, who may have a couple of other updates.
Well, before we turn to them, I think this is really exciting that you are backing up with money the movement and implementation of 988 and a continuum of crisis services. So this is thrilling news. Do others from SAMSA want to join in, have comments?
Yeah, this is Richard McCann. So I'll add a couple of things.
Wonderful.
So tomorrow, the FCC commissioners will be voting on texting 2988. And again, this will be a vote where if the commissioners approve what they have proposed, then all of the telecom providers will be responsible for facilitating texting 2988. So for most of us on our cell phones, 95% of cell phones currently have 988 operational. You can call the lifeline using 988 currently, but if you were to try to text, it won't work. So that's what they will be voting on tomorrow. And the proposed timeline is the same as for phone calls, which is that the telecom industry would need to facilitate making it operational by the same July 16th, 2022 deadline. That is an open public session that the FCC has. It's basically their monthly meeting, as I understand it. And so we'll learn more tomorrow. We think it's highly likely that it will be passing. It is a major priority of the acting chairwoman of the FCC, who has also been nominated by President Biden to be the permanent chair of the Federal Communications Commission. But it won't be official until tomorrow's meeting. So we'll try to get word out to folks around that. So the other thing I would just mention is that we are continuing to do a lot of work really on the critical issue of 988, 911 collaboration. I think I very much appreciate Ron Bruno's presentation as the central presentation here today, because there's a lot of work to be done, and it'll be important to be able to identify the appropriate roles of police, emergency medical services, 911, PSAPs, as well, of course, as states, local crisis centers, and so forth, in the appropriate unfolding of 988. So I will stop there. And I think James may be on as well, if there's anything he wanted to add.
Yeah, no, I was just looking at the chat box there, and I did want to make people, just to reiterate what John had said, was that the state funding should be announced by the end of the month. So I see that Aton and others had put the announcement for the funding that went to Vibrant, but we are eager to get that other announcement out as identified. So as soon as that comes out, we'll be able to share it further. But other than that, no, those are a lot of updates from SAMSA. So very excited to be here today and share that.
Thank you so much. We really appreciate it. Let's turn it over to Nashville. And Brian, we'd love to hear from you.
Thank you, Amy. And Amy, I look forward to being on the radio with you this afternoon at 2:30 and WIOX radio. That'll be nice. So thank you for that. I just wanted to say that the states continue to work on 988 and crisis services. They're also obviously focused on the fentanyl overdose crisis, as well as the workforce crisis, the concern about what's happening with kids and the spike of need for increased mental health services. I did want to highlight specifically Iowa. We were on a call recently with Iowa, and they were talking about their efforts regarding crisis services. But particularly what they talked about was the difficulty addressing crisis services in the rural area. And we know that this is a problem across the country when we look at where there are services and where there are not services. And the rural areas disproportionately are impacted by the difficulty in getting services. So I wanted to highlight that. NASHBID has a paper that came out in 2020, and SMI Advisor is focusing on the issue of rural crisis services, rural mental health as well. And NASHBID and SMI Advisor worked on a document together. So I want to thank Amy for that opportunity. But getting back to Iowa, I think they're coming up with some good strategies, and hopefully we'll be able to share their strategies and more as we go forward. So with that, I'll turn it back to Amy. Thank you.
Wonderful. Thanks so much, Brian. And yeah, thank you for highlighting our work in rural communities. You know, we feel like it's a really high priority, and I know many people on this call work in those communities, and I'm so impressed with the kind of tailoring they're doing there. So let's move on to our big game. Yay! Remember last week when we had the crisis hot seat, it was so quick. Dee Dee Hirsch responded in the text so immediately, knew the answer so quickly. I was so impressed with them. No pressure to them this week to answer in the chat box to this week's crisis hot seat. And so we'll move into the hot seat. And I think today, James Wright has been kind enough to say, James, you're okay with being in the hot seat today?
Okay is a interesting word. I think I was voluntold, but I am very excited to try this thing. So the rest of the team got to announce cool stuff, but I'll do the hot seat today. So
the good news is that you have this whole group to help you answer it. So let me present it to you. So this is on emergency first aid and medical care. And in 1966, the National Academy of Sciences published Accidental Death and Disability, the Neglected Disease of Modern Society. Its descriptions of communication, ambulance services, and emergency departments sound eerily similar to our current descriptions of the shortfalls of crisis call hubs, mobile teams, and crisis receiving facilities, detailing challenges in access and capacity, a diversity of practice, and insufficient community investment. So, here's your question, and I'm not going to have the tick, 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 but what example did the authors of this document use to suggest the US could do far better? Now, I will give you a tiny hint that you were chosen kinda because a little bit of your background. That's all I'm going to say. Now, you may know the answer to this. You can ask a particular friend, phone a friend, or you can ask the audience. But I've given you a little hint. What would you like to do?
Oh, it's from my background. That is interesting. And someone said seatbelts. I had, as a kid, I did not do good wearing seatbelts, but I don't think that was it. Background, either in crisis services, military, or for those that don't know, in the military, I was actually a mechanic, but that I don't think goes into disease of modern society. So in 1966 was a little bit before my time. So
what would they have used then as an example of how we can do better?
And accidental death and disability. Well, some of the leading causes of death, absolutely in accidents, are motor vehicle, and I know seatbelt was in there. So let's go to the audience here. Maybe that was accurate in its stance, but I still don't know how that ties to my background. So let's go for it.
All right. What have we got in the chat? Oh, seatbelts, Army MASH. What else we got here? What would have been an example of What do you want to go with, James? Your audience is very quiet. Where is everybody? Traffic crashes.
I know an accidental death. That's one of the major components. Let's go with seatbelts. Let's see what happens.
Okay, seatbelts. Okay, let's reveal the response. So it was your background in the military and the VA. All right.
Okay.
So battlefront emergency medical response was an excellent example. Excellence of initial first aid in the field, efficiency of the transportation of those individuals, and energetic treatment of military casualties have proved to be major factors in the progressive decrease in death rates of battle casualties reaching medical facilities across 4 wars. Look at our numbers down there. Look at how they've decreased over time as we've become better in the field, treating people quickly in the field, getting them quickly to a trauma center, and actually being able to save lives, okay? And so let's think a little bit about how does that parallel what we're trying to do now? Answering people right where they are, moving quickly to help them. I think Brian Hepburn even had a really great example this morning when we were talking with him about it.
Yes, so I just wanted to mention that Dr. Cowley, Ara Adams Cowley from Maryland, he came back from Vietnam with the idea of the golden hour, and that if you could get somebody treatment within an hour, you had a much better chance of saving them. And in our discussion this morning, it was brought up, there really is a parallel to that in terms of mental health crisis, in that the sooner we can get help to people, the better the outcome, and also the less impact it's going to have on the individual, the less they're going to need hospitalization, etc. So even though the golden hour is for physical trauma, we think it actually parallels what happens in crisis services. Thank you, Amy.
Sure. James, you see, if you let people know too much about your background, you're going to be pulled up for the crisis, James.
Yeah, totally makes sense. And that's one of the first things they teach you. And I did realize I had already been out of the military for 21 years now.
Oh.
So you kind of pause for a second there, but totally makes sense. One of the first things they teach you when you go in is responsiveness when a incident occurs, and they teach you before you deploy. So no, that absolutely makes sense. So thank you. That great hot seat question today.
Thank you so much for being a good sport and participating today. And thank you to our audience members, some of whom got the answer. So that was amazing. All right, we will move on. All right, our wave. So Sarah, we'd love to hear an update from you.
Great. Thank you so much, Amy. So the House is expected to vote on that $1.75 trillion reconciliation package as early as Thursday, potentially sometime through Saturday. We're seeing that they do not want to break for Thanksgiving recess until they are able to have that vote. And the Congressional Budget Office, who is responsible for scoring the package and figuring out how much it costs, how much it saves, should have their report on the package by Friday at the latest. So some of the members that were waiting to vote until they saw that, theoretically that should be coming forward in the next couple of days. We will then have a Thanksgiving break. The House and Senate will be out. And then when they return during the last week of last week of November, first week of December, if the package does make it out of the House, it will then go to the Senate. As some of you will remember, in the American Rescue Plan, we will go through some of the wonky procedure that happens in the Senate with the reconciliation bill, going through the Byrd process, vote-a-rama. We can refresh all of that after Thanksgiving, but it does take a bit of time. The hope is that it will pass fully out of the Senate and get signed into law by the Christmas holiday break, although there is some skepticism because there's a lot of work that needs to be done procedurally before they get to that point. Also, just keeping in mind at the same time, the continuing resolution that is currently still in effect does run out on December 3rd. So we will need another continuing resolution to keep the government open and funded beyond December 3rd into December 4th. And then there also is the debt ceiling negotiation that will need to come to some agreement in the coming months. Unclear when exactly that will come to a head, but that is another piece in the mix of the very busy end of the year season that they're having in the House and Senate. But we will keep you posted on how things develop. But hopefully this week, by the end of the week, we will see that 1.75 trillion reconciliation human infrastructure package voted successfully out of the House and then sent to the Senate for some further work.
Wonderful. So we'll have some updates from you in 2 weeks when we meet again, it sounds like. And it also sounds like your job is not one that does a slow glide into the holidays. Sounds like you're quite busy this time of year. So we really appreciate you keeping us up to date on that. And we're looking forward to updates on that in 2 weeks. I wanted to ask if anyone else has any state legislation updates right now. We have our map up. Does anybody on here have any updates that they want to share with us about their state movement? Okay. Well, I'm going to turn it over to Paul for a calculator update.
Let's see if I can share my screen. I apologize for not sending it. It's telling me no. Let's see.
Uh-oh, you may not have the controls.
I rarely do. There we go. I will do this very quickly, but it's more of a reminder of what the current calculator looks like now, which of course is a spreadsheet found on NASBID's www.crisisnow.com under tools. And you can jump in, and it's an editable calculator, which allows you to project things like demand for mobile crisis receiving center services, what flow might look like, and what that might cost. And if you go in and you look, of course, that's the main page here, and there are complex formulas. So for those of you that don't love Excel, you don't love the formula call out that's sitting there, and you don't want to edit it, which is for most people. They don't want to do that work. And in fact, the second page gets even more complicated because now we're looking at the percentage of funds for each type of service, what the state or county payment might be to do a match for those sort of services. All gets pretty complicated. And what I want to touch on just today is that change is coming thanks to McKinsey's team, and Kana Inamoto and her team have been doing some remarkable work on reimagining what this crisis calculator will look like. And just as a quick sneak peek, this is in development, so it may change from what you're seeing now, but they're creating a flow, and that flow is going to largely look at your state information, your county information, whatever you want to do. In fact, draw upon publicly available data to populate more specifically what your demand might look like, what your community costs might be influenced by. So this is a quick mock-up of a potential screen they're going to have. And as you go a little bit further, they're going to have all kinds of editable information that you don't have to go into Excel formulas for anymore, but you'll have a web-based application, one that's right in front of you where you can make those edits in real time, get to the information you want. And if you don't have it, you have default settings that are there. See, there's a broad range of different ones. You could choose to focus on specific services or do them all. In the long run, it's going to tell you what it costs. And just as a quick last visual, because I know we only have a few seconds, it's a map. And this map is going to look at specifics around needs in your community, what that looks like. It's going to consider the racial makeup of that community and other things that might influence demand for care. So again, really excited to see that work is happening with McKinsey, and I think you'll see a future iteration in early too. But for now, of course, the existing calculator is there on the crisisnow.com website.
Did you say, I'm sorry, you just went out just for 1 millisecond. Did you say in early 2022, you think this will be realized?
Early 2022 is likely. Again, the McKinsey team is doing some remarkable work right now, but it does take time to build this sort of application. It's one that is designed for those that are tech savvy and those that aren't, that can jump in and start doing this work in your community. So hopefully we'll get a more detailed update in a future session. But for right now, it is progressing quickly. And so I just wanted to show you the progress here.
I definitely think that we'll want to spend more time with you in when we get this out to really like nose through it. I know that a lot of people in the chat were saying this is going to be a game changer and that they're really excited about being able to play with this. And really to be able to get down to the county level is an amazing, amazing ability. So there's no doubt that David's going to want some more time for you in early 2022 to really help us walk through that. And for now, you know, we'll live with the old one until we get your new one. So we're looking forward to that. All right. Next slide. I wanted to let you know that we're working on cards for states as they move through the enacting law. So go back one slide for a second. So if you look at this previous slide and you look at those in dark blue or those in powder blue, those who have enacted with a fee or enacted without a fee, we're going to be making a card on each of those states. And I just wanted to give you a little preview, sneak preview of these next two slides where we've done them, one with Washington. And so here's the Washington one, and then we have one already on Nevada. So we're going to be developing these and we'll be presenting them in the coming sessions. And might be asking some of you to help us develop those for the state that you're working in. All right, next slide. All right. I think we might have one update. I'm sorry, I went a little bit too quickly, but on Washington State, do they have an update? I know that they're one of our states that are in the dark blue. Laura Von Tosh, are you here? Laura? Okay, she'll speak up in a minute, I think. All right.
Yes, I put it in the chat.
Oh, okay.
Thank you.
Thank you so much. So check out the chat for a little Washington update. So you had a minute to look at this while we were waiting for Laura. So in the blue, you can see our weeks off. You probably already got an email about it. I know I did. Thanksgiving week, which is next week. We'll all enjoy turkey or whatever you like. I like tacos, but you know, some people like turkeys for Thanksgiving holiday. And we'll also have 2 weeks off at the end of the year. But look what we've got coming up. On December 1st, when we meet, we're going to have some representatives who work in Arizona and Georgia who go from apartments to houses and work mobile crisis on the street. And we're going to have an interview with them live here on the Crisis Jam. So I'm really looking forward to that. I think it's going to be a really interesting thing to hear about their experiences. Then we've got Kimberly Boswell coming on December 8th on the Alabama Crisis System of Care. Then Melinda Baldwin from Samsa will be talking to us about children, adolescents, and family in crises on December 15th. And then we're still putting together the first of the year, January, but I just wanted to put out there that we've already got somebody for January 26th. Patrick Kennedy is going to come talk about Medicare, parity, and crisis care. So we've really got some hot things coming up. So as all of your other calls are winding down, come join us on Crisis Jam on Wednesdays, and let's learn a little bit more as we push to the end of the year. Do you have one final slide, or is that it? I think that might be it. So I was told by David to bring this to a nice, easy close. And so I just wanted to say, as we have 2 minutes probably before your next call, it was lovely to see many of you today. I really thank Ron for his presentation. I'm looking forward to a lot of the things that people talked about today that are coming up, whether they were funding, whether they're the calculator. So have a wonderful week next week with your family and your friends, whether you're having a friend giving or a Thanksgiving, and we will see you in 2 weeks. Thank you all. Bye-bye.